Welcome to Value-Based Care Insights, brought to you by Lumina Health Partners, a national healthcare consulting and leadership development firm focused on improving the strategic, financial, and operational performance of provider organizations and its leaders. On this program, we explore trends and share valuable insights on how health systems and medical groups can navigate this increasingly complex healthcare environment and shift then to transform the delivery of care. Value-Based Care Insights is hosted by Daniel Marino, Managing Partner of Lumina Health Partners. With over 3 decades of experience, Daniel specializes in helping organizations shape their strategic initiatives in areas of population health, clinical integration, physician alignment, information technology, and board retreats. For additional insights, visit our website, luminahp.com, and sign up for our newsletter. Dan, over to you.
Welcome to Value-Based Care Insights. I'm your host, Daniel Marino. In today's show, we're going to spend some time talking about payers and their evolving products and what we're seeing in the industry now as they're having conversation with hospitals, with physicians, with providers in general. It's an interesting environment that we're dealing with now, as many hospitals are experiencing challenges with costs, in particular, high inflation that's occurring. Gosh, I was talking to one of my clients, a CFO, and their labor costs are up over 8%. It's just amazing. And obviously in healthcare, if costs go up, we can't just pass on those costs to consumers by raising our prices. Our reimbursement for the most part is fixed. So it does create a real economic challenge to hospitals, to physicians. And as we're starting to see, and I think we're only starting to tap into this, the challenges with margins on hospitals are increasing. Many hospitals are continuing to lose quite a bit of money. We're seeing the government, we're seeing the commercial payers beginning to respond, but they're responding in interesting ways. They're responding by adding new products, having different types of negotiations with providers. We're starting to see and continuing to see shifting of risk occurring back to providers, all creating this interesting dynamic on reimbursement and really setting expectations around changing the care delivery model. Well, I am pleased today to have a colleague of mine who's been on the show before, extremely knowledgeable in the commercial insurance industry, with the government reimbursement industry, has negotiated numerous contracts for providers across the country. Cliff Frank. Cliff, glad to have you in the show.
Glad to be here. Thank you.
So Cliff, as you think about what's occurring with some of the contract negotiations between payers and providers, it's not any easier. I think it's getting tougher, right? We're seeing
absolutely
a lot of the providers just not coming up with good contracts with the payers. And frankly, when you look at some of the quarterly reports that the insurance providers or insurance carriers are reporting, they're actually doing financially very well. It's creating this challenging communication gap between the providers and between the carriers, all of which are really creating a major challenge for us as patients, right? What are you seeing? What are some of the things that you're hearing as you're having these conversations?
So I think it creates a new view for risk contracting. Risk contracts in this kind of environment are actually a counter-cyclical investment that providers can make. Because what's happening now is the payers are making bank on empty hospitals or slower ORs and
right, less procedures and utilization that previously happened.
That's right. And And meanwhile, the hospitals are suffering a triple whammy of higher costs for supplies, higher labor costs, and lower patient volumes.
Right. Well, and I'll tell you, some of the conversations,
that doesn't work.
No, it doesn't. And then some of the conversations that I'm having right now with payers, I'm not seeing payers increasing their fee-for-service rates, right? I'm seeing them keeping the rates the same. And in some cases, they're crying poor, where they're saying, hey, we want to reduce your rates by 2 or 3%. But oh, by the way, if you want to make it up, we're happy to create some type of a risk model in your contract so you can earn it, right? Are you seeing the same thing?
Yeah, payers are happy. It's still more in the pay for performance or a little bit of upside with a little bit of downside. It's not yet the full ACO reach kind of full delegated risk. But where Medicare goes, the payers eventually follow.
So let's talk about that for a second. ACO Reach is a fairly new product, new offering that the government has put out. And for those that aren't quite sure what it is, the Reach model is kind of the new generation of an ACO. ACO Reach stands for Realization, Equity, Access, Community Health Model. Interesting acronym for the evolving ACO model that's out there. How is that, and what the government doing with the ACO Reach model, how is that translating into either higher reimbursement for providers, or what are the payers, the commercial payers, doing to either replicate that or follow the government's lead? Any ideas?
Well, the first thing that ACO Reach is doing is it's helping physicians organize themselves. One of the tenets of the ACO Reach model, as opposed to direct contracting, was the government really wants the doctors to be in the driver's seat. 75% of the board has to be comprised of physicians.
Right.
And so independent physicians, maybe hospital employed or private equity, Village MD type organizations, they're all getting involved with this, but in a different way. That is at the local level, accountable to each other. And that network that they build and that infrastructure that they invest in, and the government is helping with that investment by providing some advanced funds, which they did not do under regular ACO. So the care coordination infrastructure the government is helping pay for. So this whole local contracting entity, this ACO Reach, is available to payers and also available for direct contracting to employers.
Yeah, that's interesting. So
a whole new table is being set here.
Yeah, you're absolutely right. So when we're talking about this and you think about the benefits of the ACO Reach model, it does a couple of things, right? So it's allowing providers to get some additional resources to help reduce their costs, right? To be able to provide support to more local providers. If there are independents in your market, there's a way to help subsidize and maybe support some of that cost, all in the name of performance and quality and outcomes. And I also see it as a mechanism in the event that this integrated network, your ACO, performs, you have an opportunity to earn some nice money off of this.
Yes, it's really designed to be a Medicare Advantage lookalike without the constraints of Medicare Advantage.
Yeah.
So this thing is either a camel or it's just a disaster waiting to happen. And there'll probably be some of both.
It's probably going to be in the middle somewhere, right?
Well, you'll have across a full spectrum, but there are going to be ACO Reach models that end up in the ditch really fast.
Oh, there are. And you saw that early on. That's happened all the way along. I could remember going way back when, the first ACO
Yeah, the next gens. Yeah,
exactly. You know, with
right.
the next
the
gen,
pioneers. Yeah,
exactly. Yes, I mean there was quite a few failures, but there was a lot of successes too. And those that were successful were really successful, and they did well. Right. So, how are the commercial carriers responding to this?
So there's a fundamental problem that the carriers have. And what Medicare is doing is it's showing or helping provider networks wrestle with this problem. And that is this: HMOs are not selling. PPOs are selling.
Right. Well, and especially in the MA space, right? HMOs, although a lot of the 5-star plans are HMOs, you know, it's restricted to a community. It's hard to advance that beyond it because of the restrictions around the HMO model.
Well, and you know, there's the primary care referral authorization requirement and all the rest of it. For that product to grow, the industry moved to Medicare PPO, which allows for direct access to specialists. It's still supportive of a primary care relationship, but frankly, it's pretty loose. So now what you have in the Medicare Advantage market is this kind of PPO situation where suddenly the providers are invited to take risk. Well, that's been an alien concept for a long time until ACO REACH comes along and does the same thing, because Medicare is a PPO.
Right.
It
well,
happens to have everybody in it.
It is.
So
I mean, if you think about it, it is
care limitation. Yeah. There is a seduction involved to have that really strong primary care relationship. But if you wake up with a sore back and you want to go to the orthopod, bypass your primary care, there's no benefit hassle. There's no benefit penalty. There's nothing to prevent that from happening. Whereas in a Medicare HMO, that could be restricted.
Right.
So there is a lot more leakage in these ACO networks, and you have to manage leakage and increase keepage in either the ACO REACH model or any of these Medicare or commercial at-risk arrangements for you to prosper. So managing who the patients see and how they get there really becomes important.
Yeah, absolutely.
That sits on a framework of a really good primary care relationship with the patient. Because if the patient has a good relationship, there'll be more connectivity. If they have no relationship and it's simply a transaction, then they're going to bounce around like a pachinko ball in the healthcare system.
Yeah, you're absolutely right. If you're just joining us, just tuning in, I'm Daniel Marino. You're listening to Value-Based Care Insights. I'm talking today with Cliff Frank, and we're having a fascinating discussion on the evolving insurance products and what we see happening both from the Medicare perspective with ACO REACH and then also from the commercials. So Cliff, as I hear you talk about that, are you seeing standard fee-for-service PPO products now introducing risk into that type of an arrangement without having it a value-based care type of a structured contract? Or are you still seeing both of those, being primarily driven from value-based care?
So it's again following the Medicare ACO model. What happens now is that there's not a direct capitation from the plan sending a check to a provider network, which then reconstructs the downstream payment stream. That's not happening. But what is happening is, say, here's a population that includes HMO, PPO, ACA plans, left-handed people on Tuesdays, and some out of state. And that's all in your risk bucket. But if you beat that total medical expense, and that's the way things usually now are hooked up with a total medical expense model, you beat that on a risk-adjusted basis, you get 50 or 60 or 70% of the savings.
Right. So it still is so it is tied to some level of performance. There is a value-based component to it, right? You have to be able to
now is
aggregate
Medicare
the cost.
has made it okay to have that gate swing both ways.
Mm-hmm.
In Medicare, first it was track C, D, and E, where you had 1%, 2%, 4% at risk, and 4% on $100 million, where you got 7,000 members, suddenly at 12,000 apiece, that's $100 million spent. That's a lot of money. And
yeah,
so you
absolutely.
could lose 4%. Well, most providers don't have that kind of money laying around. Well, now the carriers are kind of adopting those kinds of models. Well, they'll go down maybe up 20, down 10%, which is enough that's enough to get your attention. The whole thing is they want to get your attention, because here's the issue. The issue is that not that there's variation in unit price, although there is, but not that much. And frankly, with transparency, we can see that, and that's going to get squeezed out. What there is variation in clinical proclivity.
Exactly.
You got some docs who see a pulse as an indicator to do something.
Yes.
Anything.
Right.
And you have others who are much more conservative. And worse, they may both be in the same tax ID. They're both part of the same group practice. Well, it's really important to have the doctors, the primary care doctors, incentivized to send to the conservative doctor and not to the cowboy.
Yeah. So what we're talking about then is, in these new models, you have to focus on reducing the variation that's occurring between the providers, right? And as you begin to reduce that variation, you're reducing the cost differential that's occurring. And based on what the performance thresholds are, that's where you're able to make some of your money. So it truly is creating that efficiencies in the name of taking costs out.
And improving quality.
Yeah, absolutely. Yes, absolutely. So when you think about that, gosh, for many healthcare, for ACOs, for hospitals and so forth, in order for that to work, they've got to invest in their infrastructure, right? You're talking about investing in care managers. You're talking about going through some initiatives to, some clinical variation reduction initiatives. So you're taking costs out, you're preparing, you're helping the physicians become successful. I'm hearing that hospitals are struggling with that, right? They don't have the money to invest in it. So how are they going to be successful in these products?
They also don't have the guts.
Yes. You got to be able, that's where it starts, right? You got to say, hey, we're doing this, and everybody needs to be on board.
We're attacking ourselves. And if our big admitters are also the outliers, that's a big problem.
Yeah.
So making that transition, the old two canoes, with one foot in each, is really, really hard. And that's where, some of these other intermediary organizations may step in and do that either for the hospital or to the hospital.
Well, and that's where it starts, right? I mean, you have to have the directive, you have to have sort of that mission or the vision to say, here's how we're going to do things differently. But I guess to a certain extent, that will only take you so far. If you don't have the financial resources to invest in providing that delivery model different than how you're doing it today, you're not going to be successful regardless of what you say. Are you hearing commercial carriers, or are you seeing commercial carriers willing to invest or provide some resources back to the ACOs or to the hospitals that allow them to collaborate on these types of innovative structures?
Yeah, the payers will generally cough up some care management fees in the $3 to $10 per member per month range. The problem is that even when they save $5 million, when that entity, the ACO or the CIN, saves $10 million, okay, where'd that savings come from? Generally, it comes out of the hospital.
Well, it does.
So, in terms of utilization reduction. So how much does a hospital get back? Maybe $2 million, $2.5 million. So does that compensate them for the loss of the revenue? No way.
No.
So what has to happen is a combination of successful performance, but then there's got to be leakage reduction to backfill the revenue so the hospital doesn't die from doing well on these value-based deals.
You are absolutely right. So it has to be a two-pronged approach. And I think this is where, to a certain extent, some of the CFOs, some of the hospital leaders are struggling with. Not only do you have to take costs out of the system and become more efficient, you have to figure out how you expand your geographic reach, how you begin to pull the patients back into the system if they're leaking out. And frankly, if you're in a, let's say a restricted market where, you're capturing 80 to 90% of the market, you've got to figure out how you can partner with somebody else to expand that opportunity to grow your patient population. Without having those things done, I agree with you. I think it's a real uphill battle for some of the hospitals.
Yeah, I think the strategies are completely different, rural versus urban, and even mid-urban, the 2-hospital town that's got, 300,000 people or 200,000 people. That's way different than the 12-hospital market like Tampa, where the most penetration you're going to have is about 30%. So you got 70% leakage. Well, there's a hell of an opportunity there.
Yes.
Whereas if you've got 80 or 90% keepage, it's not really going to grow.
No, it's not going to grow. So I think those strategies, although I think the principles are the same, the strategies have to be different. But I also feel like as we're thinking about the payers in that market, we also have to figure out from a provider standpoint, what's driving some of the economic discussions and the economic successes for your institution. I really believe that, because payers are going to continue to put pressure on hospitals to accept less reimbursement, and hospitals just can't do it. And if anything, they need more reimbursement because they have to be able to cover the inflationary costs that are inherent in their organization. So as they're thinking about redesigning their strategic economic approach, they have to focus on how they create greater expansion, how they can collaborate, how they can bring down their costs, but I think also become creative in some of their negotiations with their payers, so you can be able to receive some level of resourcing that covers these costs and really drive some mutual success.
Yeah, I think it's going to take all of that plus an examination of, well, maybe among our 5 hospitals in the market, everyone doesn't need a heart program. Everyone doesn't need OB. Everyone doesn't need behavioral health. And you try and kind of do that clinical integration that we said we would do that we didn't do.
Yeah.
And that clinical rationalization.
Right.
So much of that has not taken place because it was just too hard. Well, now if we're going to go bankrupt, guess what?
Well, and that's a good point too. And in a lot of the conversations I'm having with hospitals, it's really around, hey, what are you doing well, right? Where do you want to put your resources? You can't provide everything to everybody, and it's unfortunate, but the economic environment just doesn't allow for that. But it also then helps to create or position the hospitals for success, and they can focus a lot of their outcomes, their cost management on those particular clinical service areas that they do really, really well. It's almost a differentiator.
Well, it is. And in fact, it may be cheaper or more effective for you to buy that other service like dialysis from your competitor rather than to provide it yourself, particularly if you're in a risk-based deal to where everything's a cost, nothing's a profit.
Yeah, so, that's absolutely true. Well, Cliff, this has been fantastic. As always, I enjoy the conversation. You bring certainly a wealth of knowledge and new perspectives in terms of where the payer industry, the reimbursement is all going. Any final thoughts or insights you'd love to share with our audience?
Well, I just think that we're headed for 2 more years of violent combat in the arena, because payers' greed is unending, because their stockholders' avarice is significant, and providers are not exempt from any of that either. They suffer the same disease. So
Right.
We're all just fighting over the same pie, and it ain't getting bigger.
Right.
We're done with getting it bigger. So,
Well, it's not getting any bigger, and I tell you, it's getting harder. And if we've got to figure out how we continue to connect the dots, and man, that line is getting harder and harder to draw.
well, that
So
line
I want to
is
thank
beginning
you
to look
for
like a tapeworm.
It is like a tapeworm. You're absolutely right. Well, my friend, I want to thank you for joining today. This has been a great conversation. Always love to have you. Again, want to thank you for a lot of your insights. I also want to thank our audience for listening today. Until the next insight, I am Daniel Marino, bringing you 30 minutes of value to your day.
Are you at a crossroad with value-based care? Do you need to chart a future strategy or improve your organization's performance? Visit us at luminahp.com to learn more about our professional advisory services and leadership development programs. Also, you can sign up for our newsletter on our website and follow us on Twitter and LinkedIn. To connect with Daniel Marino or for more information about the show, visit our website or healthcarenowradio.com. Join this conversation using our hashtag VBC Insights. We are Lumina Health Partners. Thank you for joining us today. Until the next Value-Based Care Insight, stay well.